First, many thanks for this kind invitation to give this talk. These are my disclosures, and today I will talk to you about the use of liquid biopsy for the molecular profiling of solid tumors, and of course I'll focus my discussion on cfDNA testing because this is really the approach that we are using in our clinical research. Now, before getting into this, however, I would like to briefly discuss the pros and cons of liquid biopsy testing. I've said that many colleagues, in particular medical oncologists, are really highly enthusiastic about liquid biopsy testing because this is a minimally invasive procedure that with a high compliance from the subjects. Is always accessible, is very quick, and more importantly, you can repeat several times so that you can monitor response to treatment as well as the molecular evolution of the disease. And this enthusiasm sometimes leads to underestimate the challenge of liquid biopsy testing. We usually isolate only a few nanograms of DNA from plasma, and only a small fraction of this DNA really derives from the tumors. In fact, we found a lot of normal DNA deriving from normal cells, in particular from blood cells. So the circulating tumor DNA can be only a very small fraction of the total cell-free DNA. This means that the allelic frequency of the mutations is usually low, and on top of this, the soft DNA is highly fragmented, as a short half-life, and for these reasons, we do need highly sensitive methods for the analysis of cell-free DNA. Now, when we started to test cell-free DNA, our group as well as the other groups, we've been using methods based either on quantity PCR or emulsion PCR, and this is because these techniques are highly sensitive. However, the limit of these techniques is that they can only assess few mutations per analysis, and of course, they are not adequate to provide a comprehensive genomic portrait of the tumor. That's what we need now in our research. On the other hand, targeted sequencing panels have the advantage to cover a much higher number of mutations for analysis, but targeted NGS has a lower sensitivity as compared with the other techniques. However, in the past few years, new methods for NGS sequencing have been developed. In particular, these methods with increased sensitivity have been developed for the analysis of the DNA. And among these methods, we can see there's also the anti-6. These methods actually can go down to sensitivity that are below 0.01%. Let me show you an example of what type of information you can derive from liquid biopsy testing with next-generation sequencing targeting panel. This is a cohort of almost 1,300 cases of non-squamous non-small cell lung cancer. These cases were tested first on tissue, and tissue testing revealed the presence of driver genetic alteration in approximately 30% of the cases. These are driver alterations that offer possibility for therapeutic intervention. However, almost 70% of the cases were under genotyped or not genotyped because of the low quality or low quantity of the tissue, which is actually a main issue, in particular with the non-small cell lung cancer. Well, when this cohort was tested then on cell-free DNA testing with NGS revealed the presence of biomarkers of driver alteration in additional 19% of the cases. So this is really the power of liquid biopsy testing with NGS. You can expand the fraction of cases in which you can find driver genetic alteration. Now, there are recent findings, actually several papers, demonstrating that if you find a mutation in the blood and you treat the patient with a matched therapy, the response rate is similar to what is observed when the mutation is detected at tissue level. So no difference between response rate between liquid biopsy and tissue testing. But if liquid biopsy is working so well, why we do not replace tissue testing with liquid biopsy up to now? Well, the point is that in most of the studies that have assessed the concordance between tissue and liquid biopsy testing, this concordance was very low, usually below 70%. And low concordance due to two different factors. On one hand, there are some mutations that are found in tissue but not in plasma, but there are also some mutations that are found only in plasma and not in tissue. And this is quite scary because if you have to decide therapy based on the results of liquid biopsy testing, you want to make sure that the result is highly specific. However, the study that really created a lot of discussion in the field was this one that was published last year on the University of Precision Oncology. In this study, a pharma company, AstraZeneca, distributed four aliquots of the same plasma samples to 4 different vendors that were using different NGS platforms for the analysis of cfDNA. And as shown in this slide, the results were quite a disaster. The sensitivity of these 4 platforms ranged between 38% and 89%. And even more scaringly, the positive predictive value, which measures the false positive rate, ranged between 36% and 80%. And I would say that these results are clearly not acceptable. So, but what are the factors that affect this low concordance between tissue and liquid biopsy testing and somehow affect the specificity of liquid biopsy? Well, the first is technical factors, sequencing artifacts. Why sequencing artifacts can occur with high frequency when we test with NGS liquid biopsy? Well, the point is that as I introduced, the allelic fraction of mutation involved is usually very low. And for this reason, we need to push with the sensitivity of our target sequencing pattern. And when we push with sensitivity, we fall in this gray area in which background errors increase. And so in this area, it might be difficult to distinguish between a true mutation and the sequencing artifact. Now, these background errors usually are technology dependent. And indeed, if we go back to the study that I sent you before, it's quite clear that the error from the different vendors were different, so it suggests really that different platforms that were using were inducing to different types of mistakes. On the left, you will see also that the majority of these false positive findings were found for mutations at allelic frequency that was below 1%. However, below 1%, we find often a lot of true mutations, and therefore this threshold cannot be used really to distinguish between true positive and false positive. So how can we overcome this problem? How can we, clearly solve this problem? Well, there is no general suggestion that I can give. I can show you what we have done when we wanted to introduce liquid biopsy testing with the NGS in our clinical research. What we did, and in particular, was first to test a cohort of healthy donors using this cfDNA assay based on AmpliSeq technology and specific for lung cancer. What I have to underline is that healthy donors are really challenging samples to test, because in the majority of the cases, the input cfDNA was below 20 nanograms, the suggested level of 20 nanograms. And in fact, usually from healthy donors, we can isolate very few nanograms of cfDNA from peripheral blood. Since we identified poor sequencing artifacts, we noted that artifacts because they could not identify the repeated analysis and they were not confirmed by the orbital digital PCR testing. And so what we did was to develop an algorithm based on allele molecular coverage, the allele frequency, and the limit of detection from specific mutation that allowed us to distinguish between true mutations and sequencing artifacts. What we did next was to apply this algorithm to a cohort of 107 plasma-derived cfDNA that were isolated from individuals with non-small cell lung cancer. And as shown in this table, by applying our algorithm, we got a pretty good sensitivity and specificity for EGFR and KRAS mutation, as shown in this table, with the concordance levels that are pretty good. Still, we detected some potential false positive. I'm saying potential false positive because these are mutations that were identified in plasma, but they were not identified in the mesh tissue. And in particular, we found two possible for EGFR false positive and 5 KRAS false positive. And which was more worrying for us is that 2 of these KRAS false positive were found among individuals with EGFR mutation. And we know that usually EGFR and KRAS mutations are mutually exclusive. Now, what I want to highlight, however, is that all these NGS false positive codes were confirmed by double digital PCR. This means that these are not sequence artifacts. Even if when you solve the problem on sequence artifacts, so the concordance between liquid biopsy and tissue will never be 100%. And this is due to the fact that there are other confounding factors. And first of all, the clonal hematopoietic mutation of indeterminate potential, or CHIP. What is CHIP? Well, the point is that in every tissue, in particular in blood cells, mutations do accumulate with age. So older individuals usually carry higher number of mutations in blood. And this recent study demonstrated that those individuals that harbor one or more of these 20 highly fitness variants have a higher risk of develop an acute myeloid leukemia as compared with those individuals that harbor lower fitness variants. So actually the presence of these variants might be associated with heterogeneity. Now, the genes that are most frequently mutant in clonal hematopoiesis are DNMT3A, TAT2, and other genes that are indeed associated with heterogeneity. And these results are consistent across different studies. However, it is possible also to have mutations in peripheral blood cells that affect genes that are involved in the pathogenesis of solid tumors, including JAK2, PC3, and sometimes even KRAS. And this, of course, is important because if you find one of these mutations in your plasma-derived cell-free DNA, this might represent a confounding factor. What I want to highlight, however, is that the probability to detect such mutation associated with clonal hematopoiesis is clearly related to factors, to the age, as I said, but also to the sensitivity of the method that you are using to test. In fact, if you use a high-sensitivity method, it's possible to detect the mutations even in young individuals. But if you have a method that is between 1.1 to 7.3% sensitivity, then the frequency of this bias is significantly reduced. But let me show you an example on how clonal hematopoiesis can affect the results of your test in individuals with lung cancer, as an example. These is a cohort of individuals who had an EGFR mutation, and they are tested for KRAS mutation, and in 2 cases, just like in our studies, KRAS mutations were identified by plasma double digital PCR. Now, these investigators had available peripheral blood cells for these 2 individuals. They tested the DNA derived isolated from peripheral blood cells, and what they found that in both cases, the mutation was present in this DNA. So basically, these mutations were associated with clonal hematopoiesis. As shown here, the dynamic of this mutation is quite different as compared with the dynamic of EGFR mutation in these individuals who received it in the EGFR receptor tyrosine kinase. Now, the same was demonstrated also for JAK2 mutation. All JAK2 mutations found in these individuals were found in the plasma, or in the cell-free DNA isolated from plasma of these individuals, were also confirmed in peripheral blood cells, so were clearly related to clonal hematopoiesis. However, when they looked at PC3 mutation, they found that some mutations that were detected in cell-free DNA were not identified neither in the tumor, neither in peripheral blood cells. And so if these mutations are not in peripheral blood cells, are not in the tumor, where do they come from? Well, the explanation of this might reside in the next factor that is affecting the specificity of liquid biopsy, that is the tumor heterogeneity. And to explain this, I need to just go back to basically what is the theory of the tumor evolution. We know that in order that normal cell becomes a tumor cell, at least 4 different driver mutations must accumulate in the same cell. However, after a cell has been transformed, this cell will continue to accumulate mutations and possibly will accumulate also other driver mutations. Now, what we have been demonstrated, and it's clear, is that those mutations that occur in the first phase of tumor growth and that we define as public or clonal are mutations that are present in 1% of the tumor cell. On the other hand, mutations that occur later during tumor growth that we define as private or subclonal will be present only in a fraction of the plastic cell. However, if one of these mutations is giving a growth advantage to the tumor cell or is giving the advantage in forming metastasis maybe to a specific organ, then this metastasis will be enriched for this specific mutation. And this might lead to a mutational portrait that is quite different between the primary tumor and the distant target. Now, what we learned from the studies from many studies that assess driver mutation in the cancer is that in many cases, mutations such as KRAS, EGFR, and others are driver mutations that are clonal. But still, as shown in these studies, it's possible to identify in some cases subclonal KRAS or EGFR mutation. Actually, by using target sequencing, the fractional cases in which we identify possible subclonal driver mutation is really increased. Let's go back to the 2 cases in which our study, in which we identified KRAS mutation in EGFR mutant cases. Let's start with the first case on the left. As you can see, the dynamics of the KRAS mutation and EGFR mutation were completely different in situ EGFR TKI, and the levels of EGFR mutation were significantly dropping, whereas the levels of the KRAS mutation were quite constant over the time. So what we did, we didn't have available actually the peripheral blood cells for these individuals. So what we did was to go back to the tumor tissue. We tested with the NGS and also with the digital PCR. We could not find any traces of the KRAS mutation. We looked then at the outcome of this individual who responded for 32 months to first-line EGF receptor tyrosine kinase inhibitors. And therefore, what we conclude is that although we do not have available a simple test, this case is a likely case to be in which the KRAS mutation is related to clonal hematopoiesis. What about the other case? Well, we have the similar dynamics. The EGFR mutation that clearly changed during treatment with the TKI, whereas the KRAS mutation has an opposite behavior and clearly is not motivated by treatment. So this has to be clonal hematopoiesis. However, when we went back to the tissue, we were surprised to find that in the tissue, the RAS mutation was much better represented as compared with the EGFR mutation, at least in the sample that we had available for tissue testing. Then we look at the clinic, and what we discovered that this individual never responded to treatment with EGFR TKI despite he had the 2 different activating and sensitizing mutations to the different agents were used. And so what we conclude is really this is a clear case for tumor heterogeneity. So what we learned clearly from these studies and other studies that we and other groups have conducted in this period is that really liquid biopsy testing can provide complementary information to tissue testing. We know that individuals with advanced cancer most likely have a tumor that's already formed a number of different clones, and what we do when we test tissue, we only pick a very limited number of tumor cells from a single site of the disease. However, if you use cell-free DNA, you will have a better representation of the complexity of the disease if we take into account of the limits of cell-free DNA. Really, cell-free DNA and tissue testing can provide complementary information. Now, in the last part of my presentation, I would like to show you some results that come from one of our clinical trials in which we are enrolling not only individuals with lung cancer, but also individuals with other tumor types. And basically, this is a program of prospective genomic screening that we have activated in our region, in the Campania region. Now, in this program, individuals are tested either on tissue or liquid biopsy, and these are the individuals with lung, colorectal, intrahepatic cholangiocarcinoma, or Bethesda papilla tumor that were tested on liquid biopsy. In this case, in this study, we are not using a specific assay, but we are using a pan-cancer assay, again, based on AmpliFix technology. Of course, we use a pan-cancer assay because we need to test a larger number of targets. And this is the molecular coverage. The average molecular coverage that we got for our cases was over 1900, and RNA analysis was successful in 76 out of 87 cases. And these are the genes that we found altered in these individuals, and the most frequent mutant genes EGFR, KRAS, and p53, and this is not surprising because these are mainly individuals with colon and lung tumors. And actually, next slide is showing you the frequency of single nuclear variants and indels, and we identified again EGFR 25 mutations, 6 of these were resistant mutations, and for KRAS we identified 17 mutations. Of these 3 were at low allelic frequency, and all these mutations were confirmed by double digital PCR. I have to say that now we are starting to collect also peripheral blood cells from these individuals, so in case we need to confirm the origin of this mutation, we can do this by collecting and testing the peripheral blood cells. And we could detect also quite a few copy number variation in EGFR, FGFR1 and 3, CCND2, and CDK4 in these samples as shown in this slide. Now, let me show you a couple of cases just to let you understand when we are using liquid biopsy, in which are the case in which we use liquid biopsy. This, for example, is a male, 50 years old, that was at the diagnosis of metastatic colorectal carcinoma. Now, we performed tumor tissue using the focus assay based on the AmpliFix technology. However, after repeated lines of treatment, we were asked to test plasma to assess whether anything changed in the genomic profile of this tumor. In particular, at the time in which tissue was tested, we could detect an HER2 mutation and the KRAS copy number variation. When we tested plasma, we found that we could confirm the HER2 mutation. However, we could detect also p53 mutation. We could not detect anymore the KRAS copy number variation, but we found the FGFR1 and CCND2 copy number variation. Now, this case was really relevant because the main question was whether or not this individual was carrying the HER2 variant in order to enroll in a clinical trial with the HER2 inhibitor, and actually we could confirm the presence of the HER2 variant. As we said, that we found this variant in all the samples that we got from this individual, so this is likely to be a true truncal or clonal mutation. And this is another interesting case, a 40 years old woman, diagnosed with never smoker, diagnosed with lung adenocarcinoma. Now, this lady received a test for EGFR ALK in another center and was assessed to be EGFR and not wild type. For this reason, she received 2 lines of chemotherapy. Then she got to our institution. We enrolled in our study, and using the focus assay, we could demonstrate the presence of a rare exon 20 EGFR insertion at a pretty high allelic frequency, 52%, most likely because of the EGFR amplification. Now, this is not the only case in which we receive samples that have been tested with routine diagnostic kits, and when we go back to target sequencing, we found EGFR mutations were not detected. I think this is very important, actually, to use target sequencing testing for the EGFR mutation. Now, based on these results, we started the treatment with lottery, and we started to follow on liquid biopsy the response to treatment. We usually do this in those cases in which we have rare EGFR mutation. We might not respond TGF receptor tyrosine kinase inhibitors, and indeed, after only 2 months, we could observe a slight increase in the level of the EGFR mutation. We are following this individual using the target sequencing panel, the cell-free assay, because the cancer cell-free assay, because this mutation is not covered by standard kits and not even by our global digital BCR assay. After 4 months, there was a sharp increase in the levels of cell-free DNA, and this sharp increase did correspond with a progression of the disease that was still symptomatic. The NGS test did not detect any T790M mutation, so we performed our digital PCR, and we did detect the T790M at a variant validity frequency of 0.2%. However, what I want to highlight in this slide is that we could detect only one single event that was positive for T790M, and usually we do not call the mutation when there is only one event that is positive. However, as you know, the T790M is the key to get treatment with osimertinib, and in that period, this study was published. It was a preclinical study showing that the current TGF receptor tyrosine kinase inhibitors have a little activity on the exon 20 insertion. However, among all the different drugs, osimertinib looks like it's the one that has a slightly better activity. So what we decided within the molecular tumor board was still to treat this case with osimertinib, even where we're not sure whether the T790M mutation was really present or not. And this is what happened. We started treatment with osimertinib, and only after 1 month of treatment, the levels of cell-free DNA, the EGFR exon 20 mutation in this case, significantly dropped, they become 0, and this molecular response was proven also by PET-CT scan, which showed them a clear response to treatment. So this is really the type of information that you can derive from the use of liquid biopsy. And I go now to my conclusion. I think that I showed you data demonstrating that NGS testing of cell-free DNA can provide a comprehensive molecular portrait of different cancer types. However, when we observe between the difference with the tissue and cell-free DNA testing, often there is a low concordance between these two types of testing, and this low concordance may be due to different factors, either sequencing artifacts or clonal hematopoiesis or tumor heterogeneity. So because of this, it's really important to make an appropriate internal and external validation of NGS methods before you start to use this in your clinical research. I am convinced, and I showed you some data, suggesting liquid biopsy can really provide information that is complementary to tissue testing and that can aid to personalized treatment. The use of liquid biopsy is also very important to monitor the response to therapy, in particular cases in which you may have a doubt of whether or not the individual will respond to treatment. But what I want to realize is that it's really important that the results of liquid biopsy tests with NGS are discussed within the molecular tumor board, because using these large panels, we quite often have quite complex scenarios that need appropriate interpretation. And finally, I want to thank all people from my research group as well as the other collaborators in my institution that are contributing to our research program on lung cancer.